Specialist Center. Today we are doing a mast cell tumor in a dog that presented over the past few weeks with a mass that's developed on the right lateral thigh, sitting right here, and then they did an aspirate on it. The primary care vet came back as a mast cell tumor, and the thought was that it was a sub-Q mast cell tumor. We'll just have to get that confirmed on histopath. And so we're doing a wide local excision. We did do staging just in the form of an abdominal ultrasound. And in order to close this, we're going to have to do a flap and probably a flank fold flap is what I'm thinking. And so we've clipped quite a bit so that we can bring a flap of skin back down to here and close the defect. And I think the flap is kind of going to be oriented in that direction like that. So you want to orient the flap in the direction that you have the most skin at the donor site so that you don't put the closure of the donor site under tension. And interestingly, on these cases, often we have more complications with the donor site than we do with the recipient site. So we're going to get 3 centimeter margins all the way around on this, and we'll see as we get deeper that we're going to get into the biceps muscle fascia as well as the fascia lata. So I go through the skin using my blade, and then I usually use my electrocautery for the rest of the dissection. And you'll see that in this case I'm probably going to have to take out a substantial portion of the thickness of the biceps muscle. And I have found over the years that the dogs really don't need their biceps muscle. So I think our ground plate is not good. No, it's good. Yeah, it's working. Sorry, my mistake.
I didn't realize you had to take the muscle with the most.
Yeah, so you need to get a muscle fascia.
Yeah.
And the problem is that with the biceps muscle, it's hard to separate the fascia out from the muscle without actually taking partial thickness. Like anywhere else, like on the antebrachium of dogs, you can take that antebrachial fascia without taking the muscle, but on the lateral thigh, you can't.
Yeah.
Because the fascia is so closely adhered. I have a couple of guest surgeons today. Anthea was one of my former interns about 8 years ago. And Sonia was one of my interns at South Paws from last year. It's always fun to have old friends scrubbed in. They also know exactly how I like things done, so makes for a very smooth surgery, hopefully. So I'm down to the biceps muscle there, distally. I might raise the table a little bit more. We're still on the field there, yeah. We have Jamshed Cooper, who's from India, watching. I met Jamshed in Hyderabad when I was doing a lecture there, when my wife and I were there for a conference. And he's always been a great follower and always keeps in touch and sends Christmas messages and greetings and stuff. Yeah. All right, so I'm just going to put some tension. Find that when you're using electrocautery to cut through tissue, keeping it under a little bit of tension really helps those tissue layers to separate. So I'm going through, so that's fascia lata right there, okay? And underneath that is going to be vastus lateralis. And then this kind of combines, so the fascia lata combines with the superficial biceps muscle fascia. Can I get cautery turned up, please? Maybe 45 and 45? Thank you. So that's biceps muscle there, and that's where it goes into muscle fascia, right there. So usually what happens is that I try to peel the fascia off, but as I go farther distal, I end up taking almost full thickness biceps.
You want me to put tension here for you?
Yes, please. All right, so you can see here that I'm trying to peel that fascia off the
Yeah.
biceps muscle.
And you're just using the coag on that?
Yeah, I always use coag rather than cut,
Yeah.
because cut, you'll see, just cuts too much.
Yeah.
And it's kind of hard to control, whereas the coag setting is much easier to control. The other thing we could have used here would have been laser,
Oh, yeah.
because you don't get the muscle fasciculations
Okay.
that you do with the cautery. So I'm trying to get partial thickness here, but it's so hard because it's so closely adhered. And whatever I do, I don't want to penetrate that fascial layer, because then my margin is compromised.
Yeah.
Might get some towel clamps here. That's great, thank you. And I will infuse all of this with bupivacaine, because I think that cutting through the muscle is, or can be, quite painful. And I've done an epidural on this dog as well. Whenever you're doing any kind of surgery, one part of your checklist should always be, is there a local block that I can do? Because local blocks with the sodium channel blocker like lignocaine or bupivacaine is the most effective pain relief you can achieve, and also the least side effects and least toxic to, or least effect on cardiopulmonary function. So I know I've done an epidural, but I've got this big cut surface of muscle here, so I'll probably go ahead and do a local block as well. So to see how much of that biceps muscle I'm taking.
Yes, I understand now. Yeah. And this leg will function normally.
It'll be walking tomorrow on it.
Wow.
Yeah. As I often say, it might be at a selective disadvantage if it was fighting for its own food in the savannas of Africa,
Yeah.
but on the sofas of Brighton, it'll be fine.
Yeah.
And we've got one opportunity here to get a cure,
Yeah.
and so we just go for it. Can I get some bupivacaine, please? All right, so that's my partial thickness fascia underneath that, so you can see that really clearly. And Jamshid just said that he's doing an internship, rotating internship at Oregon State University, which is really exciting. Following your career path, Jamshid, over the past several years. It's probably been 13 years since I was in Hyderabad, and I think you were a vet student at the time. So, very exciting. All right, so we've got this big wound here. We don't have to worry about, because the toxicity of the epidural or the epidural already had passed. So I'll just go about 6 mils. Yeah. All right, so we've got it. That's biceps muscle there. That's vastus lateralis fascia, and that's fascia lata. right there. And so I'll probably just close that across like that. And then I can't really do much more. The only question is whether I could close this primarily. It's going to be under a lot of tension, so I will go ahead and do that flank fold flap. I'm very confident with my margins here, so I'm not worried about contaminating my donor site, which is something to consider. Where can we get the most? I think probably something like that. It's going to be the way to go. All right, so then bupivacaine is really toxic if it goes IV, much more so than lignocaine, so I have to make sure that I'm aspirating each time I'm injecting to make sure I'm not in a vessel. Can I please get some OPDS? Might as well inject some into the skin. Whatever I have left, I don't know that I have a lot left.
Do you want any saline?
I'm good for the moment, thank you. So I'm just going to close that biceps to the fascia lata there. Thank you. Thank you. So other than a flank fold flap, guys that are watching, any other reconstructive options here? Any other axial pattern flaps that would be appropriate? So for the lateral thigh in a dog, we've got flank fold flap, which I think is the best one. That's why I'm doing it. But are there any other ones that anybody can think of? Yes, so caudal superficial epigastric, and then there's one more. Actually, two more. So the deep circumflex iliac, which comes out right here at the tip of the iliac wing. You have dorsal branch and ventral branch. So that would also work. And then you could also do a caudal fillet, where you fillet out the tail, and you've got two big vessels that run down either side of the tail, and so you'd amputate the tail but keep the skin, preserve those vessels, and that works really well as well.
Have you done that many times?
I think I've done it once.
Yeah.
Yeah, it's reported, but I've only done it once. So there's a question about do I really need the local if I've done the epidural? Look, probably not, but it's not going to hurt anything. And I'm just really concerned. I just want to make sure that we've covered all our bases as far as pain relief is concerned. So I'd rather have a little bit of overkill, because as I would imagine this would be pretty sore. So this is the flap that I'm taking, kind of like this. And lengthwise, basically, we need to measure the distance from this corner of the flap here to the farthest reaches of the wound, which is up to about there. So that'll cover it. And we'll lift that up. That's getting a bit tight up there. Lift that up a little bit more there. And now I'm going to draw my flap, kind of making sure that I'm going to leave enough skin behind so that I'm not going to have tension on my donor site. Let's see how that looks, and then relax that. So that'll be plenty to close the defect. And I'm checking again to make sure that I'm going to be able to close the donor site. And that length should be plenty. All right, so, and then this is going to have to close to that. So the biggest tension here is going to be right at that corner,
Yeah.
right there. That's deep circumflexionic right there. That's that ventral branch. Yeah, so that vessel that's bleeding a bunch right there is deep circumflexionic ventral branch. And if you're thinking about getting into axial pattern flaps, the flank fold flap is the best one to try first because it's the most robust and the most versatile. Okay. So what I might do is just try to re-aim the camera a little bit. And zoom in. All right, so now I'm going to use my scissors to elevate the flap so I don't cause vasoconstriction on the feeder vessels. And just lift this up here. And just get ready to put pressure down on the bed if I cut something big that wants to bleed. I'm going to keep a lot of fat with the flap. This brother is bleeding over here. Did I drop a Jabaki?
Yeah, you did, but I don't think you might should have two in there. We need some brown. Oh, yeah, that's what I meant.
Can I get another? Oh no, that's I've got a Debaki. No, all good. I've got my Debaki there. My old friend. My dad was a cardiac surgeon, and one of his examiners for his boards was Dr. Debaki.
Oh, wow.
Yeah. And have you ever heard of a Cooley forcip or vascular clamp? Well, that was named after Denton Cooley, and his other examiner was Denton Cooley.
Oh my gosh. So cool.
And then there's a textbook called Sabiston of human surgery. His other examiner was Dr. Sabiston. It's a fairly intimidating group.
Yeah.
Yeah. All right. So now what we have to do is this guy. I'm going to lay this down where I think I want it to go.
Yeah.
Then I'm going to take some towel clamps. And just kind of try to space it out kind of generally how I think it's going to go. Like that. And I might extend it just a little bit more. So I'm not under tension. And then do we have another towel clamp? Or is that it? That's all right. Let me
Do
just
you
see.
want this one?
Yes. Thank you. All right, so then we'll bring that up here. All right, so that's how it's all going to go together. And the way we sterilize the Sharpie is with ethylene oxide. Otherwise, you can buy sterile skin markers that are probably $3 a piece or something. I just think the Sharpies write a little bit better. So that's going to come together nicely. So I'll just start on the sub-Q over here. Can I get some, maybe some 2O PDS? So we'll just do a nice, deep, thick sub-Q over here. Getting a little bit of a dog ear. Trying to actually get into the abdominal wall fascia a little bit to try to draw tension away from the skin edges a bit.
Do you worry about dead space or not really?
I'm closing it yet. So I am a little worried about dead space, and so I am tacking underneath as I go. The other question that I often get is, should I put a Jackson Pratt drain in here? And I'm not too concerned about dead space here, and so I won't, because drains do increase the risk of infection because it's a big foreign body in there, and so unless I really think I need it, I'm not going to use a drain. Some people say you should use them every time you do an axial pattern flap. I'm not, I don't subscribe to that. All right, so that looks great there. So I might have you, Sonia, do an intradermal. Actually do a kind of a superficial sub-Q.
Yeah. And we'll do skins on top.
And then we'll do skins on top. So the layer that I want you to get is this stuff here.
Yeah.
Okay.
You tell me, do you want to move where I am?
You're probably okay there. Yeah.
Can I get another 2O, please?
Just tell me if you need me.
No, you're fine. I'll just try my best.
Sonia will just elbow you.
Feel free.
All right, so now I'm just going to do a sub-Q layer here. Let's see.
Do you want me to come on that side?
No, you're good. Good as gold, thank you. I'll just see if we've got some bleeding along the edge here. Sure we will, but yeah, we've got a little bit of arterial bleeding right there. So that's
Do you
great.
wanna see?
Yeah.
Oh,
No,
sorry.
that's okay.
Sorry.
Yeah, no, that's so fine.
Do you want me to put it down rather? Up to you.
It's okay.
Here you can use
Thank you. Are they just
nails.
nails?
Yeah.
Yeah.
I'll try to keep it on.
And I'm not going to tack down the middle of the flap because I don't want to compromise any of the blood vessels within the flap. So I think that's coming together really nicely. Thank you.
Sorry, Charles.
No worries. So this dog had a couple of other little masses on the left shoulder, which I aspirated, and they were just lipomas. But I was just saying to, so Anthea was the referring vet, and so I'm just telling her that we need to monitor those and make sure that they don't grow, and if they do, to re-aspirate them.
Yeah, the same with the one on the chest.
Yeah.
Do you ever take fatty lumps off just in case?
If I know that it's a lipoma, I won't,
Yeah,
unless they're doubling in size in 30 days or impeding function.
yeah,
Honestly, it sounds like overkill. One of the best diagnostic tests, as you would know, Anthea, from your internship, is CT. And so if you have a dog that has 20 masses that you think are lipomas all over its body, you can just CT the whole body and see which ones are actually lipomas and which are something else. So whole body CT scan is actually a pretty good diagnostic test. I mean, you don't need to CT every lipoma, but
no.
but if you have somebody that's really concerned, it's a good way to go. Get Clint Udelman to come over and
Yes, in the parking lot.
yeah. There's an internal medicine specialist in town who bought, he's always done mobile ultrasounds, and he's bought a CT scanner in a truck. And he drives around to practices doing CT scans, and it's an amazing service and so good for general practitioners to have access to such a great diagnostic modality. And like I always say that if you went to your GP, your human GP, and you had to have a CT scan, they don't have a CT scan in the back. They're going to send you to a radiology center or to a hospital and get the CT, and then they're going to work with the results. And so if you have that option available as a vet GP as well, that's just a great option. Now I reckon I'm going to come around that side.
Yep.
So you stay where you are. Well, you come over here. That's great. I'll just change the direction of my needle. Release this guy. You know what? Can I get a couple of sterile skin staplers, please?
Yeah.
I normally don't love skin staplers, but this skin is nice and thick. And so I think the skin staples will hold quite nicely.
Yeah.
Awesome, thank you.
No worries.
One of that for a second, please. All good? Still on Sonia's?
Sorry?
I just was saying I stole your...
No, that's fine.
All right, so come down from this direction first, and you want to make sure when you're using skin staples that the skin is thick enough that it'll fill the staple. Otherwise, the staple kind of wobbles on the skin, and it doesn't provide a good seal. And you want to push down as you staple to get more skin, because they're made for human skin, and human skin is thicker than dog skin in a lot of places, on the belly and stuff like that. Yeah, so
Would you like skin stitches for the donor side? Right?
no, I can staple it. Yeah. Number 2. So there's a question about the fact that, or the question as to whether the local will already have worn up by the time the dog wakes up. And we're using Marcaine, which lasts 4 to 6 hours. So it should last well into the afternoon. We have done an epidural as well, and then we will provide methadone as a supplemental analgesia. Make sure I haven't missed anything down there. That's all good. So the most tension on this whole repair is right there.
Yeah.
So if we had a problem, that's where it would be. So we just have to make sure we restrict them. All right, so that's pretty much it. I'll just go back and make sure I haven't missed any questions. All right, Egypt and a few other places. So, all right, so that's it. We'll leave it at that. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. We'll see you.